you're working in a place where you come across human beings, eventually you're going to come across a kidney transplant patient. Hello, Dr. Humans! This week I wanted to bring you something high yield indeed. How to manage renal allograft dysfunction. Now, this lesson's actually included in my brand new program, Rock Your Long Case, which, by the way, is an absolute blast. And if you are studying for your RACP clinical exam, you are invited and you can check out all the details and sign up using the link below. But even if you're not studying your clinical exam, this will still be relevant because as Dr. Humans at large, kidney transplants show up, right? They pop up everywhere in rural settings, in tertiary settings, in GP practice. And so if you're working in a place where you come across human beings, eventually you're going to come across a kidney transplant patient. It's inevitable. It's in your future. So I wanted to share this lesson here with y'all because it's so relevant to clinical practice no matter what field you're in. So let's go learn how to save those kidneys. So before I go into how we should approach this, I wanted you to do a 30-second brainstorm, just thinking about if you had a kidney transplant patient in front of you and they have graft dysfunction, their creatinine's gone way off, what kind of things would you be thinking about? What would you be wanting to do in terms of investigations and getting to the bottom of that? So I'll give you 30 seconds, little timer starts now. Okay, beautiful. So how did you go with that? So as with all things in the long case, I would advise that you keep things very, very simple. So even if you have never seen a kidney transplant before, you've never managed a kidney transplant patient, I'm willing to bet that you have managed acute kidney injury and that you're actually pretty good at this by now. So I would just start with those basics and do what you normally do, and then we're going to stack on the transplant specific problems. So first of all, just going back to this very familiar concept of pre-renal, post-renal and intrarenal. So pre-renal, thinking about any hypotension, any dehydrating precipitants like diarrhea or vomiting illness, any drugs like non-steroidals or ACE inhibitors or ARBs that might be contributing here. In the post-renal space, we're going to be thinking about all the usual causes of obstruction. So prostate, stones, tumours, blood clots, all of that. Intrarenal, we'll be thinking about if they've had a prolonged pre-renal injury, could this be ATN, acute tubular necrosis? Could there be interstitial nephritis from a drug allergy? Or could there be a glomerulonephritis, either a recurrent GN or a primary de novo GN in this graft? All possible. And then we're going to add on the transplant specific problems. So coming back to post-renal, we're going to do an ultrasound looking for all of the causes of obstruction that I've just mentioned, but we're also going to look at the donor ureter. So remember that the donor ureter is foreign tissue and it's been stitched into the bladder. And depending on how that's healed over time, it might be narrowed or there might be a stricture there. So we're going to look and see if there's a ureteric stricture. The other anastomotic connections are, of course, the artery and vein. So we're going to do a renal artery Doppler looking at those vessels, so looking for renal artery stenosis and renal vein thrombosis. For intrarenal, we're going to think about pyelonephritis first of all. So this is not unique to the transplant population, but they are predisposed to this, and I'm going to tell you why. So this donor ureter is much shorter than a native ureter, and it also doesn't have any anti-reflux mechanisms. So if you have infected urine in the bladder, that can easily track back up into the transplant kidney and cause pyelonephritis. So this patient group is very susceptible to this. We also have rejection, of course, recurrence of their primary renal disease. So if they had a vasculitis or primary FSGS or something like that, that can come back in the graft and we have to be alert to that. BK nephropathy is something I'm going to come back to shortly, but BK is a little virus that loves to hang out in our urinary tract, and then when we're immunosuppressed, it can ramp up and can cause graft failure. So we'll talk about that again shortly. CNI toxicity, so your tacrolimus cyclosporin, particularly when the drug levels are very high, can cause an acute kidney injury. And thrombotic microangiopathy. So this is a little bit more small print, but this can be associated with tacrolimus and cyclosporin, with the CNIs, and it can also be a manifestation of rejection as well. So when we're thinking about intravenous causes, we're going to do the bloods and the urine. We're going to look for, what was their baseline creatinine versus their more recent trends. We'll be thinking about, is there any infection in the urine, any blood or protein that might suggest a glomerular injury, all of that. And of course, you could go on to do your GN screen if it was relevant. We're going to do drug levels, checking if the drug levels are too high, that might have CNI toxicity, but also if they're too low and might convey a risk of rejection. We're going to do a BK virus PCR in the blood, so a blood test rather than a urine test. And for thrombotic microangiopathy, the clues are going to be there on your full blood count. So the pattern you're looking for is a low hemoglobin and low platelets together. And if you see that, you would then go on to do your hemolysis screen, your blood film looking for schistocytes, your coags, which would be normal, your Coombs test, which would be negative. So all of those things. And of course, if you do suspect an intrarenal pathology, the test that's going to clinch your diagnosis is a renal biopsy. That's going to diagnose everything shown here. But just to say that if you did suspect pyelonephritis, you don't really want to do a biopsy in that situation. So you want to exclude that before you get to the stage of biopsy. So we're going to look at the urine and even the imaging for clues on that. Because if you think about it, if you have an infected kidney and that's localized, and then you put a biopsy needle in there, you can cause a bacteremia if they didn't have one already. So although it technically would show up in a biopsy, we don't want to diagnose it with a biopsy. And just a little extra point is that sometimes you can have a kidney transplant, but you can have it in the context of having another organ transplanted as well. So a heart transplant, lung transplant, liver transplant, or even a pancreas transplant. So if you do have graft dysfunction in one, think about the other, especially if you're thinking about rejection and things like that. And a really easy tip is if someone has a kidney transplant and a pancreas transplant together, the easy way to check on the health of the pancreas is to do a lipase and a glucose. So just in case that comes up for you. So that was how to approach renal allograft dysfunction. I hope that helped your studies and comes in super handy in your clinical practice, or of course in your long case. And if you are studying for your clinical exam and you'd like to become oh so confident managing transplants and many other conditions, then definitely check out that link below. Come along to rock your long case. We would love to have you there. Thank you so much for watching, and I'll see you again soon for some more higher learning. Bye.